How's it going, everybody? This is Ken Miller with the National Academy of Sports Medicine, and I'm here with our buddy Tony Ambler-Wright. How you doing, Tony?
Fantastic, Ken. Hey, everyone. How's it going? Happy to be back this week.
Yeah. This is our fourth week now in our series for our Return to Performance webinars, and every week's getting better and better as far as what we're able to address as we figure out how to put together the OPT model when it comes to getting an athlete or somebody who's recreationally active from some kind of injury state or less than optimal movement situation back to performance, or if they weren't in that shape that they needed to be in, using this optimum performing training system to get somebody there. So last week was the knee, and the week before that, the foot and ankle. So if you are not familiar with what we've been doing so far, the overview is a great place to start as far as getting familiar with how we look at getting that client or that patient or that athlete of yours involved with return to performance. So today's topic is going to be related to the hip complex. So I'm coming to this webinar from Alameda, California, which is in the Oakland Bay Area. And Tony is out there all the way across the country, out in Atlanta, Georgia. So the reason why I bring you up to speed on where we are, the thing about it is when it comes to application of this system, this is something that works great from, working with any sport from anywhere. So Tony, being the professional that he is and involved with the athletes that he's been working with or has worked with in the past, this is one of those things where it's always fun for me to connect with you, Tony, when it comes to learning how you've applied the system. And when it comes to the hip, this is a very impactful region of the body. And basically, as Tony and I have prepared for this webinar, there was a million ways we can go about it as far as how to address it. So Tony, just a little bit of overview. When you're working with an athlete and looking at how someone moves, what are some of the considerations that you've taken when it comes to working with this region of the body?
Yeah. Ken, I think like we've discussed with the foot, ankle, the knee, and as we'll get into next week with the shoulder, everything is connected. And so while you may have patients, clients, or athletes that end up with a pathology or injury in this hip region, oftentimes just based on that regional interdependence or kinetic chain approach and look at things, you'll quickly find that, not only will you see things locally that may need to be addressed that could be contributing or that contributed to why they got injured in the first place, but you may also have to look more globally at areas above and below the hip to also see what might have influenced that region and could have led to increased stress there that ultimately led to the injury. So, for me, I always go back to the system that we have at NASM, where we go through a series of assessments. Each assessment basically helps you uncover more and more information, helps provide you with greater insight into what might be the underlying contributing factors to whatever your patient, client, or athlete is dealing with, and what you're trying to help them get back from with their training program. So, for me, it starts with the foot and ankle. We go through the 5 kinetic chain checkpoints. And we'll kind of talk through our recommended assessment process here in a few minutes for this region. But basically, look at the entire body, how it functions in an integrated sense during a variety of different movement patterns, and then break that down into more local or isolated segments to see if we can really find that root cause and the areas that we need to prioritize from a programming standpoint.
Right, and that's awesome, because when I was looking at, just pictures of the anatomy of the hip, as complex as that area is, you have to have multiple vantage points on how you would program design, like you're talking about. But well before that, figuring out how, what is it that we need to flesh out as far as, what component or what joint within the hip is actually experiencing the deficit. So, just to talk about a little bit about anatomy of the hip, it's what they would call an osteoarticular ring, right? When you have how the ilium and the sacrum and the pubis, all connect to form a ring, right? And any one of those points can cause stress throughout the whole system, right? So when we're talking about the iliofemoral joint, the iliosacral, the pubic symphysis, lumbosacral, even to move up a little bit higher, there winds up now being, okay, well, fleshing out of, okay, well, how's this area doing? How's that area doing? How's this area doing? How's that area doing? So just locally, there's enough to look at. But as you're talking about with regional interdependence, some of what the problem may be, like if someone's experiencing some kind of hip dysfunction or even pain, that can be coming from someplace else.
Yeah, 100%. And with respect to the anatomical structures that you just mentioned, or the joints that you just mentioned, iliofemoral joint, for those of you who may not be familiar, that's the interface between the ilium and the femur. So basically our ball and socket hip joint. Iliosacral joint is where the ilium and the sacrum interface. And so as the ilium moves on the sacrum, that's what we would define as iliosacral movement. And then, screensaver, guys, sorry, I haven't fixed that yet. Got me again. Then you've got the pubis, where at the front of the pelvis, and then you've got the sacroiliac joint on the back of the pelvis, where again it's the same interface between the sacrum and the ilium, but sacroiliac movement is essentially when the sacrum is moving on the ilium versus the ilium moving on the sacrum. So you may see those referenced in that way because of how the movements are taking place and how those structures are interacting with each other. And so, yeah, you're absolutely right. There are certain things that can be local to the hip. For example, if somebody has, let's say, anatomical changes to their iliofemoral joint, where they have, let's say, a cam defect or something like that with the shape of the femoral head, that could be limiting movement of that iliofemoral joint into rotation, then there have been some studies that show that there's increased movement at the pubic symphysis. So it just kind of reinforces this whole thing that if there's limited mobility or limited motion available at one segment, it's going to have a direct impact on the adjoining and adjacent segments. And that increased movement may lead to increased stress over time, which could then lead to some type of injury or pain experience for your clients.
Right. Yeah, that's that's a lot of information. So one of the
I'm always good for that. Yeah. I told you gotta keep me in line.
I'm writing my notes as you're talking, but again, it's just one of those things where with everything that you're saying, again, you talk about the iliosacral and then the sacroiliac. There's books just written on that joint alone, so that's a lot to digest. But going forward from the joints, now you have to talk about all the muscles that cross over that regional anatomy, right? So now we're talking about the pubis or the pubic symphysis. Now we're talking about the muscles that connect and influence that area. So now we're talking about the adductor complex, And again, getting back to the sacral region, now we're talking about the glute max, glute medius, hamstrings that connect into the lower part of the hip, into the ischial tuberosity, um, or the ischium. So what we're talking about now, joints, now you have to talk about the muscles that cross over. So, and that's what really blends in. Okay, well, what's happening at the knee, what's happening at the low back, and what's happening at the shoulder, to where someone can be experiencing some kind of pain or discomfort in the hip region, but it could be emanating from how the muscle's interacting with, a joint that's maybe, an area that's one joint, or maybe even sometimes two joints away, when it comes to, understanding your functional anatomy. So with that, and I'll let you say your perspective on that one, Tony. But this is where we, as fitness professionals, or anybody that works with the human body, has to have some study, or quite a bit of study, when it comes to how muscles interact in the human body from an upright position.
Yeah, absolutely, Ken. So when it comes to the muscles, again, when we talk about programming, we'll focus not only local to the hip complex and the muscles there, but we may also have to focus our attention maybe down even at the foot and ankle complex or around the knee, because how those muscles, all those muscles rather, excuse me, influence what goes on more proximally at the hips and pelvis.
Right. So let's get into a little bit of the we discussed anatomical considerations. So when it comes to something, it's something I've been watching, for years now, with a lot of the presenters out there, when it comes to activation of the hips. Not to jump into programming too far, but when it comes to things like, because you've been trainer for over 20 years now, when it comes to the squat, which has been a very popular, which is one of the best total body exercises, out there, squats, lunges, things like that. How much consideration do you give towards anatomical differences when it comes to, and this is something that's come up a lot when I've presented workshops to personal trainers. How much consideration do you give for anatomical differences in performing squats and lunges? Like, how much leeway? I mean, there's the textbook, parallel lines between trunk and spine, spine and shin, and things like that. So how do you look at the body, or appreciate the differences that each and every client offers, and how do you address that in your assessment process?
Yeah, so I think, one, we've talked about this as a group as well, just understanding the difference between an assessment and, how you might program a squat as an exercise. They may be the same, they might be different. When it comes to the squat, let's say from an assessment perspective, we need to standardize the process. So we're always going to have the same setup, feet oriented straight ahead and parallel to each other, roughly, hip to shoulder width apart. And by standardizing that setup, that allows us to be more objective and reliable in our observations. And it allows us to better track progress and changes over time. When it comes to setup for squatting as an exercise, I tend to start off the same way. My goal would be to try to get somebody to be able to perform a squat with ideal ankle, knee, hip, and trunk orientations, with the feet pointed straight ahead, and anywhere from hip to shoulder width apart. Now, I start there. Obviously, there are certain anatomical considerations that you may hear of, like hip anteversion, hip retroversion, which is a change in the angle of torsion of the femoral head and neck. Anteversion is basically going to be when the femoral head and neck is oriented more anteriorly, which will basically place the hip into a position of greater internal rotation. You might notice a little bit less stability at the hip joint and a more toed in gait with somebody who has, true anteversion at the hip. And then retroversion would be the opposite of that. The angle of torsion is oriented more posteriorly. They're going to be biased more towards external rotation at the hip. It is a more stable position at the hip, and then that individual may feel more comfortable in a more toed out type gait pattern. And so when you look at the percentage of the population that has true anteversion or retroversion, it's relatively small. And there are specific tests that can be performed in order to determine the level of anteversion or retroversion, but within the scope of the fitness professional or strength and conditioning coach, that's not really within our scope to do those tests. And so for me, I always just approach it that I'm dealing based on my other assessments. I'm likely dealing with more of a muscular imbalance and an alignment issue due to either muscle tightness or muscle weakness. And I'll address my programming and address my client's exercise position based on that. And over time, if I'm implementing what I feel is the correct programming based on what I see, and I'm not seeing changes, or if trying to get my client into certain positions creates more pain and discomfort for them, then that may indicate that there's some underlying anatomical considerations that we have to look into. And it may necessitate us modifying our programming because of that. So I think the goal for me would be to try to get somebody to move well from a more neutral orientation, feet straight ahead, hip to shoulder width apart. And once they've demonstrated good control and the ability to move that way and throughout multiple planes, they've achieved ideal range of motion at the key joints involved, then that to me provides the freedom to be able to have more variability in the programming. So if at that point I want the person to squat with their feet externally rotated and take more of an abducted position at the hip, then fantastic. Or if you want to do things with a more internally rotated position, narrower stance, it just allows you a lot more, the option for a lot more variability if your client has that optimal range of motion in all planes of motion. So until then, I want to try and get somebody to function well within that neutral range, because if I allow them to move in the positions with which they're comfortable, I'm likely just going to reinforce some of the imbalances that I've identified and observed with their movement and with their mobility assessments. So if, for example, if a client lacks hip internal rotation and as determined by my mobility test, and during the overhead squat, I noticed that they assume more of an externally rotated foot alignment. Maybe they have to go wider, abduct and externally rotate at the hip due to that limitation in hip internal rotation. If I just allow them to continue to squat that way, it's just going to perpetuate tightness in the muscle and overactivity in the muscles that are forcing them to squat that way in the first place. And so over time, I want to try to gradually reverse posture, reverse pattern, if you will, what they're comfortable doing. But if I don't notice changes or, there's an increase in pain or discomfort and things aren't improving, then I may have to refer out to a qualified practitioner to be able to do some of those more clinical and advanced tests or imaging to determine if there's other things going on that are outside my scope.
Right. So, and no, I appreciate you sharing all that. I mean, it's a lot of great information, because I just remember when I was still a strength coach, and we would have 6 racks, and it would be time to squat, and we as a team we back squatted the players, and through my time in the weight room, when you would have 3 people working, 12 people working in, or 18 people working in at the same time, I'm just going down the line, And as we're squatting, you're noticing, different low back positions, different angles. And, you got two racks going on at the same time. And being able to watch these two players move totally different, but, the end goal being, get their thighs parallel to the ground and then stand right back up. So, some of the players, you just have to say, all right, hey, I need you to keep your chest up, but more importantly, let's get those feet a little bit wider, because I'm starting to see your knees cave in, or just put a little bit more focus on keeping those knees out and tracking within the hip and the toes. So appreciating individuality. I mean, some players felt an immediate difference as far as maybe some stress that they were experiencing the low back because of the compensations, or what the hip was not able to do under a loaded squat. So the low back started to kick in, and that's one of those things that goes into appreciating everybody's different anatomy. And so from that perspective, that's one of those things that I think our listeners or our viewers need to understand, is that everybody's anatomy is different. And to the point that you made, is that if someone has an anterior or retroversion, in all my years of working with athletes, I've had one person who was a very high level athlete for his sport, had an x-ray, brought it in, and it actually showed how anteverted his hip was anatomically. So, now, after seeing the x-ray, you feel bad, because all those times, hey, you got to get lower, man. You got to squat deeper. If I'm gonna pass you off on this workout, getting this, checking off that you squatted this much weight, you got to get lower. And once that x-ray came across the desk, for us coaches, we're like, oh man, all this time, we're just thinking, he wasn't pushing himself enough, but it was a disregard for physically what he was bringing to the table. So, of course, since then it's always been one of those things where now I've like, okay, well, we'll let this go, or let's find something else that we can do outside of a squat. Well, maybe instead of a back squat, maybe a front squat where we're loading the hips differently is an option. And with, like what you're saying, maybe toe out a little bit, maybe a little bit wider. These little micro adjustments, in time did lead to a big difference in this athlete's ability to move. So thank you for sharing that.
For sure. Yeah. And you bring up another point, exercise selection. I mean, while squats are great, you have plenty of other options too. Whether it's a modification to the squat itself. You mentioned changing range of motion requirements, but you have step ups, lunges, split squats, rear foot elevated squats. I mean, there's a variety of different things that you can implement as the trainer or coach to still get a great stimulus and training effect without exacerbating what might be going on with the athlete. It's interesting with squatting, since we're on the topic, when it comes to full range of motion and, what will be considered ideal. There was a study, I think it was by Rhea, a couple of years ago, that looked at the difference between quarter squat and full squat effect on power, measures of power output, like sprint time and vertical jump performance. And what was interesting is, as you'd expect, let's say the quarter squat group got better at quarter squatting, the full squat group got better at full squatting, their performance increased accordingly. But the quarter squat group had better improvements in their sprint time and vertical jump performance. And so when you look at transference of training, and the specific positions that are required for the athlete to perform on the field, on the court, and so forth, just doing a full squat for the sake of doing a full squat doesn't necessarily translate to improved performance outcomes. And so that's where, again, if you look at the athlete as an individual, you take into consideration their maybe their structural limitations, their capabilities, and modify the programming based on that, you can still see improvements in their performance, which I think ultimately is the end goal, is how they perform on the field, on the court. how they're contributing to the team's success, not just trying to get them to squat, perform a full squat for the sake of doing it, or because that's what everyone else is doing, if that doesn't have a
Right.
measurable impact on why they're training in the first place.
Right. Right. So let's load up the bars and quarter squat all day long.
Yeah. I'm all about that.
Yeah. So okay, we kind of jumped a couple points already with addressing exercise and programming,
Yeah.
regressions and progressions. But so before that, before we even get to the point where we're putting the bar on the back, like we were saying earlier, you need to be able to assess someone's ability to, the individual's ability to accept load, right? So, so that leads us into the assessment process. And again, in putting this webinar together, there's just wound up being, the list kept growing as far as how we look at the body. What are we looking for? Again, once you've fleshed out, okay, it's not the foot and ankle, it's not the shoulder, because when it comes to compensations, compensations can start from the top and work its way down. They can start from the bottom and work its way up, or they can start in the center and then work its way out. So, which leads us to looking at the lumbopelvic hip complex, or in this conversation, just the hip complex. So when it comes to the assessment process, we look at, static, dynamic, transitional, things like that. So with the hip, what's the area, or how do you assess just from a static standpoint? Because I remember when I was more of an active massage therapist, and I asked my client, hey, what is it you want to work on today? What area would you like for me to spend more time? And while they're talking and I'm listening, I am doing just like kind of doing one of those little just scanning them up the bottom, top to bottom, bottom to top, and
Terminator.
Yeah,
Terminator
exactly.
style.
I got the little red light beaming from my left eye. So now it's like, okay, so he's telling me what he wants me to work on. So that's one assessment. But then statically, or looking at his static position, I'm looking at, okay, is he hiked up here? Has he had a drop there? What are some of the things that you look at as far as the hip complex from a static position?
Yeah. So local to the hip, definitely want to look at the position of the iliac crest. One, we want to look at it in the frontal plane. Is it level in the frontal plane? Or is there a hip hike and relative hip drop on one side or the other? Also looking at the orientation in the sagittal plane and transverse plane. Is there any type of rotation involved in the transverse plane, and any type of deviation in the sagittal plane, whether that's more of an anteriorly rotated pelvis or a posteriorly rotated pelvis? Those are going to be the big ones. And, some of those things are hard to eyeball. So kind of guiding your client through different motions and movements may be able to help you better determine what position they're kind of more resting in, if you will. So if you're assessing, let's say, an anterior pelvic tilt, or if you're trying to determine if a client is in more of an anterior tilt than might be considered ideal, have them go through some active anterior and posterior tilting. And so as you ask them to perform an anterior tilt, try to assess or observe how much motion they're actually going through, and then have them perform a posterior tilt and see how much movement and motion they're going through. And if they have more relative motion going into a posterior tilt, then that would indicate that they're probably resting, or their static posture is in more of an anteriorly rotated position. And vice versa. If somebody has more mobility or is able to move a greater amount when they tilt forward anteriorly, then they might be resting in more of a posteriorly tilted position. So those are just some really simple assessments you can do. I will say, globally, I'll take a look at the foot and ankle complex as well, because we know that, a more of a pes planus or flattened foot posture can have a direct impact on pelvic alignment, particularly anterior tilt in the sagittal plane. So for every few degrees that the feet flatten, that can change the amount of tilt in the pelvis substantially. So if we're looking at or working with a client who's got some hip complex issues that we're trying to flesh out, we do want to pay attention to the foot and ankle complex as well, just to see what's going on there. Anything else that you look at, Ken?
Well, I mean, you pretty much covered it, but to talk about the anterior and the posterior pelvic tilt, I think there's a lot that goes into that a lot of trainers don't realize. You know, for one, to see somebody like you explained, if you instruct an anterior, you know, so if you give the analogy like the bucket full of water, you want to spill that water to the front of your shoe to explain the anterior pelvic, because I mean, when you're talking anatomy, anterior pelvic tilt, it's like, what does that mean? What do you want me to do?
Yeah.
It's like, yeah, I want your belt buckle to point down towards the floor, or that water bucket analogy. So for an anterior pelvic tilt, spill in front, a posterior pelvic tilt, spill back behind you. And one of the tools that offers from personal trainer to client, athlete, patient, is that now it's a way to start learning each other's language, right? So when I'm telling you to spill that water bucket forward, or I'm going to say anterior pelvic tilt, mention it, but I'm going to talk water bucket because for the most part, everybody understands water bucket. So to go off of that, you know, we're establishing some communication. I know that now if I'm talking about it, you know, are you a tactile person where you need to feel it? Are you verbal? So, you know, do I just need to say it a different way? Or visual where I just need to explain these things? So that is the assessment process is a part of the, you know, laying the groundwork, or, you know, laying the path to communicate for future sessions. So there's that point with what you're talking about with performing an anterior posterior pelvic tilt, but there's also the fact that, you know, where are they initiating movement from, where I've seen people, you know, just, you know, I've demonstrated, explained it, just like I've told you, but what happens is that they lean back, right? Or they'll hunch forward. All the motion's coming from someplace else other than that region that we're talking about. So now we're having you know, a bigger insight on what their mind body connection is. Because if they can't do that, or if they're trying, it's like, I'm trying, you know, I'm really trying to spill that water onto the front of my shoe. Now we know that the proprioception, or your kinesthetic awareness of where your body is, you know, forget about us talking and me trying to get you to do something. You're trying, and I honestly, you know, want to give you credit for trying, but you're having trouble trying to do those things that I want you to do. So that gives me an idea really now of, you know, there's what I feel like we can do when I start to program design, but whether or not, you know, you can do it is another thing. So now, again, I'm always about trying to put the athlete into a position of success, give them these small wins. So now you gotta step back in your conversation and really, I don't say dummy it down, but you got to speak to their level of comprehension when it comes not just to, you know, speaking and do this or do that, but also with speaking their body's language. And the hip complex is a great area to kind of figure out, you know, how much awareness, how much control do they have of that region? Because it could be that, like what you're saying, if you tell them to anterior pelvic tilt, and you know, they get maybe a centimeter, they're trying, but then they go the other way and they have all that range for that posterior pelvic tilt. Well, yeah, you're right. They're already there. So I can kind of check off that box as far as that tilted position. So when it comes to the anterior and posterior pelvic tilt, that's one instructional phase of a onboarding session. That not just gives me an idea of, okay, how are they holding themselves? How are they possibly loading their spine? You know, when it comes to their day to day, but also how do I need to communicate with them moving forward from here?
Yeah, so, fantastic. I actually used the the bucket of water analogy this morning with a client. Uh, Not on an assessment, but doing a programming a reverse crunch.
Hmm.
So yeah, oldie but
Yeah,
goodie.
it is definitely an oldie but goodie. And then now moving forward from the, if you're skilled and you've been trained in palpation, you can actually, and you're qualified, certified, licensed, you have the qualifications to put hands on clients. Then palpation is another means of doing it, but there's so much to be gleaned from the ability to have the client actually do it. So I'm more in favor of the instructing the anterior, posterior pelvic tilt, find the middle, and moving forward, that's where we can consider your neutral spine. So again, when it comes to the forces that cross the body, from upper to lower, from left to right, when it comes to things like walking, you have two times the force coming through that area. When you start to run and jog, 5 to 6 times stair climbing, 6 to 8 times the forces coming through that region, or even when you're talking about jumping. Now, depending on what you're reading, 10 to 12 times body weight force coming through that area. So, and that's just to really emphasize how important this region is, because nothing gets to the upper body and nothing gets to the lower body without going through that hip complex, right? For somebody that's upright.
Yeah, for sure.
Yeah.
What about, do you look at greater trochanter at all? Is there anything you look at specifically there, statically?
From the greater trochanter, again, more from a palpation standpoint, to use my hands, again, open palm, trying to get a feel for where that is. Now looking for, is one higher than the other? And again, you mentioned it earlier, the foot and ankle complex has a lot to do with how that area of the body is going to be lined up. And then from there, again, looking at the iliac crest, looking from that vantage point, is that now affecting that? Or if it isn't, now we can start to figure out, so clear some things off the table, and whatever's left is the things that we have to work on. So from a greater trochanter standpoint, I'll address that if I'm palpating that region of the body. But what assessment processes have you incorporated to look at femoral position from that standpoint?
None really. I mean, I think there's some assumptions going on, right? Just based on, the study that we referenced quite a bit, Camus, in 2007, kind of alluded to this a few minutes ago. When there's hyperpronation present at the feet, that's going to have a direct effect on femoral internal rotation and then anterior pelvic tilt. So as you mentioned, if there's just an increase in lower extremity pronation, then you're going to see those greater trochanters are probably going to be a little bit more prominent on palpation. They're going to be they're going to be oriented a little bit more anteriorly, and then you're going to see that increase in anterior tilt. So the greater degree of pronation or foot flat-footedness rather, that you see, then you're likely going to see more internal rotation at the femurs and more of an anterior tilt. So yeah, I was just curious if there was anything you did specifically. So cool. So with that, statically, got some great things to look at, and then we always have our transitional assessments: overhead squat, single leg squat. What are some things that you want to be on the lookout for when dealing or addressing the hip complex as it relates to those transitional assessments?
Yeah. So when it comes to the assessment process, again, I'm building up my database on how this person's moving. So when it comes to these now transitional assessments, they're going to confirm or deny some of my observations from the static postural assessment, right? So as someone is squatting now with their arms up overhead, now I'm just going to look at with that lumbopelvic hip complex, are they initiating with a low back arch, right?
Yep.
Are they forward leaning, knees coming in? So now I'm figuring out, okay, well, when we look at the hip complex in concentric, it's going to extend, abduct, externally rotate, which means that eccentrically it decelerates flexion, adduction, and internal rotation. So if I'm now seeing the knees are coming in with that anterior pelvic tilt or that excessive low back arch, just to look at that region, hopefully it's for some people, they may look great statically, but then once you get them moving, then things start to pop up. So I'm going to use it to kind of get more information. So as I'm noticing those compensation patterns through that region of the body, those are basically, just to look at, from the front, from the side, but from the posterior view now, the big thing that I'll see with a lot of, let's say, especially rotational athletes, is a lateral hip shift. So this is where, when they're in the descent of their overhead squat, you'll start to notice a shift one way or the other, which now gives a different protocol for the right side versus the left side. So from there, now things got a little bit more intricate when it comes to the movement preparation part of their programming. So again, if it's an athlete, they may have no symptoms, right? So except for, a couple compensations, but if that shift leads, one way or the other, now it's like, okay, well, now we have to treat the right side a little bit different from the left concepts. The steps are going to still be the same when it comes to inhibit, lengthen, strengthen, and integrate, but how we get there with right versus left now becomes a different story.
Yeah, no doubt. It's at the ASS shift, asymmetrical weight shift. Yeah, absolutely. And I'll look forward to diving into that a little bit more when we get into the programming, because I think that how to address the weight shift, that comes up quite a bit in our workshops and student questions, just trying to conceptualize the relative asymmetries between the two sides and then what that means from a programming standpoint. I think, hopefully we can break it down in a way that makes it a little bit easier to conceptualize and then understand how to program for that. So
right.
Great points.
Right. And then what builds on top of that now is the ultimate humbler assessment, which is now the single leg squat. So this is one that puts a lot of people in check from the standpoint that, and I'm sure you have too, Tony. You work with somebody that's competed at the highest level possible, but when it comes to doing a single leg squat, you've seen, like, how is this guy a gold medal winner, and MVP, it's won their conferences or whatever, and they can't stand on one leg, right?
Yeah, I've seen some atrocious patterns. I know you have too.
Right.
Makes you appreciate the abilities that much more.
Right. And that's why, like, I'm really, I'm what I call, I'm in demonstration shape. So if I can put my hands on my hips and then go ahead and get a squat, and I get 5 good ones without that, without getting that little kickstand help from that foot that's in the air. By the time this athlete or person is squatting, it's like, how did you do that? It's like, well, it's just years of training. But it's just, if I can get 5 good ones, that's all I need to do from a demonstration standpoint. But yeah, and it's gone the other way too, where somebody that they may not be operating at a high level, and they can do those all day long, right? But yeah, so my point in bringing that up is, just because somebody's a really good athlete and they've operated at a high level and seemingly, injury free, doesn't mean that these assessments, whatever they may be, if it's new and novel to them, they haven't rehearsed it, which makes it really, makes those movement patterns for assessment wise, the better pattern, because they're not rehearsed at it, they're not practiced, they haven't laid down the motor patterns to gain success at it. So single leg squat, especially with the hands on the hips and not in a pistol position, will tell you a lot from someone's ability to, for one, stabilize, right, balance on that single leg during the descent, but also when we start to look at the hip drop or a hip hike, or if their shoulder turns in, or they start to rotate out, or maybe even a little bit of a shift. Everybody's got a different strategy, and to now see how the knee reacts, how the hip reacts, and how the upper spine reacts when somebody's on a single leg, just from the vantage point now that, when we look at the gait cycle, someone just walking, 85% of that gait cycle is going to be on a single leg. And then now when you talk about someone who's running, 100% of that running cycle is going to be on one leg. So it's one of those things where I do need to know how you operate, or how your body functions on a single leg.
Yep, no doubt. Yep.
So that again.
What are some of the things you would see on a single leg, Ken? What are things that you would be looking for that would be less than ideal, especially for this region?
Yeah, for this region, especially when you talk, when you start to put together like some of the complaints, where they might experience tension, irritations in the hip, I might watch out for, or have my eyes peeled out for, a hip drop, right? Mm-hmm. So as you squat, let's say I'm on the right leg, so now if I'm squatting and my left hip is now dropping lower than my stance leg, that's what we call a hip drop. Or maybe their strategy is to hip hike, where they shift everything over to where now I'm not using not as much of my muscular system, right, as well. I'm just balancing over the leg and trying to get much of my mass over that standing leg as possible to take off some of the stress on the muscular joint, or the muscles around that joint, right? So the other thing too is just watching out for hip rotation. Anything that takes us away from that ideal alignment, to where it's saying, okay, I need to bail out my glute because my glute isn't strong enough to hold the hips level, or it's not strong enough to keep my shoulders square above my hips. So I'm watching for rotation and a drop or a hike when it comes to that single leg squat. Now, some people, it's just doing a single leg stance, or just balancing on a single leg. These compensations can pop up. And I know that when I have somebody do a single leg squat, my template, rep range is going to be 5. But if someone shows me right off the bat that they can't control themselves, I'm going to say, all right, after 2 reps, I've seen enough. We're good. Let's do the other leg now, right? Yeah. So I'm looking at also bilateral symmetry right there. So if somebody has a really good squat on one leg, but they have something that's not as good, and noticeably not as good, like some people can squat really well on the right, and maybe they have to keep tapping that toe down on their left. That's something to note as well. It's not, and that just doesn't speak about the hip, but also that whole side altogether, because it says, okay, I can control load, balance, stability on this side, but this side, not so much, which again, it's all being brought into the bigger puzzle as far as how well can this person move and control their body, for this initial phase of their training.
Yep.
Yeah.
Cool. So, from there, we can start to get into some specific mobility tests, right? Look at range of motion at some of these different segments. And, for this region, some of the big ones are going to be, looking at hip extension range of motion. So doing the Thomas test or modified Thomas test, particularly in clients where you might notice an excessive low back arch, hip abduction and external rotation, which is going to assess the extensibility of the adductor complex. Then you can also look at hip internal rotation, and not only are you looking to see, can you achieve benchmarks here, but we're looking at symmetry in particular, because that pelvis is at closed ring. If there's an asymmetry where one side is less mobile than the other, that's going to have a direct impact on the entire pelvic complex. And so with hip internal rotation, you can look at the hip. You can look at the hip internal rotation from a prone position, as well as from a seated or supine position, if you will. Our benchmarks there are 45 degrees in either position. And typically individuals who have some complaints of pain in the hip complex and hip region, as well as up into the low back, you're going to see some limitations in that hip internal rotation range of motion. You might also see limitations in hip abduction and extension as well. We do want to look at hip external rotation. And then some other things, just doing like a straight leg raise to assess hamstring extensibility. You could also do the 90-90 knee extension test if you wanted to look at that. And then lumbar flexion and extension, as well as trunk rotation. So a lot of these things, we're focusing a lot of our attention on the hip complex and conditions that your clients may experience there, but know that a lot of things that go on at the hip are going to influence low back issues that your clients might have, as well as, next week when we get into the shoulder, stuff that's going on in the upper extremity can also influence the low back. And so similar to the knee getting caught between the hip and the ankle, the low back lumbar spine is caught between the hips and the upper extremity and upper quarter, and can be influenced by either. So a lot of the things that we're talking about here, if you have a client who's coming back from some type of low back pathology or low back injury, a lot of things that we're covering here will also apply to that individual as well.
Right. And, with that said, when somebody has an ability to control their body and we're actually evidencing, as we're seeing this evidence through their movement pattern, you have we have the overhead squat, single leg squat, the Thomas test, and all those prone internal rotation. As you start to gather those data points, and then not to say that if someone comes to you because they've been referred to you because they have some kind of pain or discomfort, it doesn't mean that we're just hanging on every word as far as their injury is concerned, because we want to be sensitive and we want to be able to show them that we care, because we do. And so these data points have to coincide with, okay, well, what's this person experiencing? What they're experiencing is real and is reasonable. And that in and of itself is another data point. So to take everything that you discussed with those individual movement assessments, internal rotation, hip extension, external rotation, now we start to figure out, okay, why is this region of the body experiencing all this stress? And because apparently the amount of stress and the force that's coming through that area exceeds the tissue tolerance for that load, and that's why there's been some kind of irritation and why somebody's feeling uncomfortable. So when we start to talk about things like piriformis syndrome, sciatica is in that same conversation, bursitis, groin strains, or as we have here, groin disruption, hip flexor strains, and all that. All these data points feed into, okay, well, why is there so much going on stress-wise in this area? And in conversation with other trainers that I know that have listened to our other webinars, and yes, Tony, we do have listeners for our other webinars. Yeah, we do.
We do. Oh wow.
Yeah, we do. Some of them we're hoping to actually have like templates of, okay, well, my client's got this, this patellofemoral syndrome, but you didn't tell us how to do it, right? And that's not the point of this webinar. What we're trying to instill upon you is, okay, everybody's got a different reason for why they have pain, right? So even though if we say it's a hip flexor strain, there's a multitude of reasons why somebody has what's been diagnosed as a hip flexor strain, whatever that means for that person. But what you're trying to do as a fitness professional is be able to figure out, okay, where is this person not moving but should, right? And where are they moving but should it, right?
Yeah.
So you take all these points and now you can figure out what it would take for this person as an individual to move better. So we can talk injuries all day long, but we just bring them up just from the vantage point of, if you hear these things, it gives you some insight on what, where the irritation's happening, but you still have to look at the body overall and be able to put together, what's moving that shouldn't be, and shouldn't be, or as much as it is moving, or that area that should, but is not, right?
Yeah.
So,
Yeah.
so
And the
when we,
injury, the specific diagnosis, to your point earlier, is that's where the capacity or the tolerance of that particular tissue is exceeded. That's, whatever the underlying mobility limitations or excessive mobility in certain cases in a particular region led to greater stress on that particular tissue or tissues or structures than others. And so, we don't want to chase pain. We're not. It's not within our scope to address the injury specifically. But it's interesting with a lot of the things that you mentioned, Ken. Bursitis or trochanteric pain syndrome, which you might hear of, piriformis syndrome, hamstring strains, all the groin stuff, FAI, femoral acetabular impingement syndrome.
Yep.
A lot of those, when you go back to the mobility assessments and the movement observations that we just discussed, many of them can essentially be drilled down to a lot of the same things. With increased femoral adduction and internal rotation, limitations in hip extension, increased anterior pelvic tilt. All of those are going to stress those tissues that we just mentioned. So,
right.
It's interesting. Just anterior pelvic tilt is a big one, and not only can that affect things like the hamstrings and the sagittal plane, create more tension through those guys, adductor magnus, as well as increased reliance on those muscles because the glutes may be in a less than optimal position in somebody who has that anterior pelvic tilt. But when you increase the anterior tilt of the pelvis, that can lead to a decrease in hip internal rotation. So you might see up to 10 degrees loss of hip internal rotation. And you might see up to 10 degrees loss in hip flexion, right? So when we talk about our functional movements and, going back to our athletes who squat, if you're trying to get an athlete to perform a cheeks to sneaks or full squat, and they have an anterior pelvic tilt, well, if they've lost 10 degrees of hip flexion, they've lost 10 degrees of hip internal rotation, then that's going to increase increase the likelihood of them sustaining some type of impingement sooner, right? Because the hip joint basically runs out of range of motion. And so those tissues are going to, or structures are going to hit end range sooner. And that's going to lead to more global compensation. So you might see a posterior pelvic tilt or a lumbar flexion towards the end range of a squat because of some of these things. And so, it's interesting how many of the injuries, many of the aches and pains in this region can be attributed to a lot of the same underlying factors. And so that'll be reflected in the programming for sure. What's interesting too, sorry, you gotta reel me in here in a minute probably, but just
put it out there. Just put it out there.
With respect to that increased anterior pelvic tilt, what they found, I think I mentioned, if you have somebody with a cam deformity of the femoral head, well, individuals with that deformity may have decreased range of motion overall. Changing the position of the pelvis has a similar effect. So somebody with that type of anatomical deformity, where there's that bump on the femoral head, that's going to limit their range of motion. But then when you factor in the positional faults of increased anterior pelvic tilt, that's just going to further decrease their available range of motion. So regardless of whether you're dealing with some anatomical stuff or not, anatomical considerations, you still can't ignore the other stuff that we're talking about. You can't just say, oh, well, it's an anatomical thing and there's nothing we can do about it. Because you can certainly mitigate and prevent things from getting worse or getting exacerbated as a result of some of these movement faults. So I think that going back to our earlier conversation, you certainly want to take anatomical differences into account and into consideration, but it doesn't mean you should just throw out some of these other things that we're talking about, because you can still, even if you can't reverse or significantly improve
Mhm.
what you're finding, you might be able to prevent things from going further down the path in the wrong direction.
Right, right. And and we do need to talk about programming soon, but to kind of
Yes.
piggyback onto all that, I mean, and something that you and I have talked about many times, you have an athlete that's been, let's say, a professional athlete for years, and they've just been in and out of the training room, right? So they'll come in and they'll basically treat whatever is aggravating the player, and then they'll be post surgery, or they'll resolve the pain issue somehow, but then they'll get back to their regular strength conditioning or practice or workout routine, and then they might feel something else, right? They might have another issue. So one day, and this is where, like when I'm watching, when ESPN was talking about, when we had sports going on, somebody might have a foot and ankle issue, like an ankle sprain, but then later on in the season, they may have a hip issue of some sort, right?
Mm-hmm.
And that's one of the beauties of figuring out, okay, what is the best, when we're talking about return to performance strategies with the assessment process. I mean, outside of looking at, specific individual, considerations like what you were just talking about. Now we have to talk about, okay, well, do they have the control, and can we address that issue before we get them back into their regular routine, so that if we do the battery of assessments from a static to transitional, add in a gait assessment, local assessments, looking for internal, external, knee extension, all that good stuff. But how do we get the player athlete stronger from this process than where they were before, where they were just constantly revisiting either for the same injury or just related injuries, because you had that layering effect of excessive anterior till now we have excessive low back arch, and now we have excessive knee valgus. That all, if we pick one muscle, the glutes definitely come up, or even intrinsic core stability winds up being an issue from that vantage point. So a lot of good points there, where again, we're not chasing pain, but what we are looking for is movement efficiency. And can you move efficiently and effectively as a human first, and then as an athlete or position player second? All right. So with that
So when
said,
it comes to I was gonna say, with that said, or when it comes to that, then what do we do? What do we do,
right.
buddy?
Right. So for the hips are a big issue, and you're not going to find any workout plan that doesn't include the hips, right? I mean, well, back in the day when you just use a bunch of selectorized equipment, you can sit on your butt and then do your press, do your row, do your pull down, do your leg press, and the hips have minimal involvement. But now that, let's say in a facility like mine, where you are working with open space, or if we're working with athletes that have to be able to move in different directions, now we have the hips have to take precedence when it comes to preparation. So as we've talked about, as far as program design in these webinars, it's going to be basically the corrective exercise strategy as the National Academy of Sports Medicine teaches it, with inhibit, right, to get the muscles to relax or to down-regulate overactive regions of the body. Then we have to lengthen. So those that have been shown to be in a more shortened position, we've got to get some length, and that's going to help recruitment patterns, so that when we get into the third step for activation, now we have a better opportunity, or more opportunity, to activate and upregulate the activity in an opposing muscle group. Okay, and then the integration process. And in the integration process, as we've discussed it with both the knee and the foot and ankle complex, as we will here with the hip complex, is that now we will add more sports-oriented activation exercises or movement patterns to get somebody to be in an environment where they can, look, touch, feel, smell more like the activity, like what they're going into. So, just to kind of take on, let's say, as a pseudo case study, looking at something like a piriformis syndrome, or somebody is expressing, symptoms, or has been diagnosed with sciatica. Just to give us a working template on how we might get somebody to move better with the typical compensations that might come along with it. Tony, where would you start if if that was the scenario you've been posed with.
Yeah. Well, I think first, just so we're all looking at the same sheet of music, or coming at it from the same sheet of music. Piriformis syndrome generally is a condition or scenario where the piriformis muscle is overloaded in some way, and that overload creates some type of inflammation that's having an influence on the sciatic nerve in that region, and so that may present itself as some deep pain in the glute region. You may get some symptoms down the back of the leg, sciatic-like symptoms. And so I guess what we have to do is we have to understand, okay, why is the piriformis getting overloaded? And so typically what we see is, the piriformis is a relatively small muscle when you compare it to the glutes. But often when you see clients who present with, let's say, a lack of hip internal rotation during their during their mobility tests, maybe during their functional movements, squat, single leg squat, you're going to see increased adduction and internal rotation of their femur. That may be indicative of decreased glute activation, glute max and glute medius. So the glute max, as you mentioned before, during functional movements, the glute max, its primary job is to decelerate hip flexion, adduction, and internal rotation. Glute medius is going to, posterior fibers in particular, are going to decelerate adduction, internal rotation, and flexion. And so if those guys are relatively underactive due to a variety of different reasons or potential causative factors, that piriformis is going to have to load share and take on the brunt of the work as a result of synergistic dominance. And so, the relative size of that muscle compared to the glutes is small, and it's not going to be able to handle that amount of stress. And so that's going to lead to that inflammation on that particular structure, and that's going to cause the pain and could potentially create pressure on the sciatic nerve. We can't ignore the influence of that potentially on the adductor magnus and biceps femoris as well, where synergistically those muscles are going to become more active if the glute medius and glute max are not keeping up with what they need to. So then, with that, more traditional approach for somebody with that deep glute and posterior thigh pain would be, let's stretch the heck out of the piriformis. But based on what we just described, that piriformis is already eccentrically overloaded, so it's already getting lengthened repetitively under load. And so stretching it may offer some temporary relief, but it's just essentially reinforcing the stress that's already being placed on it during movement. And so I think from a programming standpoint, what we would want to do is inhibit the piriformis, so we could perform a myofascial technique like rolling, or use percussion and vibration over that muscle. That'll help to kind of down regulate that muscle, decrease its overactivity without trying to increase its extensibility. So perform an inhibitory technique on the piriformis, and then from a lengthening standpoint, lengthen the muscles that could be contributing to that stress, that increased stress on the piriformis. So perform a stretch on the rectus femoris, right? So if this is a client who has an increased anterior tilt and excessive low back arch, and we want to address the hip flexor complex. So look at the rec fem. Also perform maybe a lengthening technique on the biceps femoris, adductor magnus, maybe the anterior adductors if there is an anterior pelvic tilt. So inhibit the piriformis, lengthen the rec fem, biceps femoris, adductor magnus, and then from there we can get into our strengthen or activate exercises for the glute max and glute medius. And there's a host of fantastic techniques that we can use for that, and basically just select the best one based on your client's ability to perform the movements without compensation. We also can't ignore the anterior core. So again, if you're dealing with a client who has an anterior pelvic tilt, we want to perform exercises that are more anti-extension focused, that can help bring the pelvis back into more of a posteriorly oriented position, or closer to neutral. So, things like dead bugs, quadruped opposite arm leg raise, maybe even some crunch variations, planks if you want to get more advanced. And then, side planks if you want to look at more of an integrated exercise for the glute medius. And then from an integration standpoint, we want to try and get them moving well in all planes of motion, utilizing multiple drivers. So, following the proprioceptive continuum that we laid out a couple webinars ago, using a variety of different resistance modalities, different body positions and speeds. So, starting off with, let's say, a 2-leg pattern like a ball wall squat, for example, where you can load the hips with minimal dependence on foot and ankle mobility. You can maintain and encourage more of an upright trunk and spine position, which will decrease stress to that piriformis region. And then you can progress to maybe more of an alternate type exercise, whether that's a step up, inline lunge, in different planes. And then, from there you can get into your single leg exercises, where now that hip has to really, those glutes really have to work to control the hip and the lower extremity on a single leg. You can also incorporate tube walking, both side to side, front to back, diagonal. Again, just getting the entire hip complex to work in multiple planes while maintaining good core alignment. So making sure to prevent falling into that anterior pelvic tilt, where again, we're putting that piriformis in a position to have to take over for the glute complex. And then from there we can get into some of our performance oriented drills, and that can be jump squat progressions. What are some other things where you might use the upper body as a driver to create stress through the hip, like single leg balance with maybe shoulder swings, or before that you could even do maybe a single leg windmill, where now you're moving the upper body through space to create more stress and perturbation through the hip. What other stuff would you throw in there, Ken, from a more dynamic performance oriented standpoint?
Yeah, increasing to a reasonable level, just the complexity. So like like the stuff we might do for other programming things, like a side lunge to a balance, but now to do a side lunge balance and then add what you mentioned as far as an upper body driver. So I'd say side lunge, balance on my left, and then rotate left, and do the same thing to the other side. So just adding another step to what they might do for a regular client. But if I'm going to be more athletic or performance driven for a sport like baseball or swimming or whatever it is, I might add in another complex step, or maybe add in like a light ball toss. You mentioned perturbation, so to give them that impact to where now they have to isometrically stabilize or anti-rotate from a balance standpoint, or even just get on 2 legs, it's side step, or we're doing like the tube walking you mentioned, and add a little toss and go. That could be a tennis ball or a 4-pound med ball, something like that, just to add now these drivers, these slow incremental rotations with every step. Again, they have to earn their way up to these progressions, or I'll just give them a little pause so that I can give them these little wins, as we mentioned before. Give them these little points of success that just helps them realize that they are getting closer to the end. But pauses, balance and holds, adding complexity, adding perturbation. So now not only may I throw a med ball, toss it lightly, change the amplitude of the velocity, where the implement's coming at them from different directions, different speeds, or I might be behind them, kind of just tapping them lightly on the shoulders, maybe on the the side of the ribs or something like that, just to give the hips just a different a different interaction with force than something that's predicted with the motion that I've just instructed them. So yeah, it doesn't have to be, activation doesn't have to be, or integration doesn't have to be complicated. It just has to be reasonably progressed, for one, safety, but for two, as a confidence builder to get this person in the mindset of thinking about their sport.
Yeah, I can do this without hesitation,
Right.
That unconscious competence. Right. Yeah, for sure.
Yeah,
exactly. Would you utilize things like, let's say if you're in more of a, fitness oriented facility, would you use an agility ladder, or could you incorporate anything like that into the mix for some of these things?
Yeah, I'd want to harvest whatever I could from what they've already done in the past. One, because if I can show them something, a new way to look at an old tool, like you mentioned, speed ladder. What sports coach doesn't have a speed ladder, right? So you have the zigzags in and out, and you just add a pause, right? Or like they go lateral zigzag, so they go in and out the other side, and just 2 feet on the ground, pause, in and out, pause. Or to progress that, in and out, and they pause on their outside foot, that other foot's in the air, and then boom, boom, and pause. And that's one of those things that, a lot of high level athletes may not have experience with, because it's always been about speed, because it's a speed ladder. Well, from a reintegration standpoint, we got to crawl before we walk before we run. So from that vantage point, taking what they may already be familiar with, cones, speed ladders, resistance bands, things like that, but just have them use it from an integrated standpoint, from corrective exercise to performance, before they use it to its, how they may have initially learned how to use those tools. So just putting breaks in there, adding some complexity, getting their body to get stimulated in a different way when it comes to these drills, because again, they've been compromised for some reason or another. And the ultimate goal with return to performance is to get them back to sport stronger than they were when they actually got injured to begin with.
Yeah. Awesome stuff.
Yeah. So on that note, I think that's a good place to end it. And when it comes to what we're going to do next week, obviously what we talked about today bled into a lot of what we discussed already with the knee and the ankle, but just to show you how integrated things are. But what we didn't really touch on is how the hips, or the hip region, or the hip complex, also affects the upper body. And we're going to definitely discuss that more when we do return to performance on the shoulder next week. And Tony, I say I can't wait till to open up this box of tools and exercises, and especially talking about, because you've had a strong experience with baseball. So I'm really excited to see what we have to share next week.
Yeah, as have you. Yeah, be careful what we wish for, right?
Exactly.
Might be 2 hours next week.
2-hour webinar.
And
all right, so
with that, folks, I don't know if we mentioned it or not, but if you have any questions, feel free to type them in the comments section below, and we'll make sure to address them next week before we get into the topic at hand. So thank you so much for your attention and listening, joining us for our return to performance on the hip complex, and look forward to seeing you all next time. And Ken, thank you as always, man. It was a pleasure.
Thank you, Tony. Yes, always. All right, everybody. All right. Take care and be safe.
Take care. Bye-bye.